And it's recording. Okay. Can you just look through that and make sure that...
Make sure you're gonna aim on, make sure she's on there.
Okay. Today we are on week four, okay? So Marjorie is sending out an email today about test dates and how, I'm not quite sure, I think she's pushing hers out to next week, but she's gonna have that in the email. As far as the lab quizzes go, lab quiz 1 is now gonna be next weekend, next Wednesday. That will be the 14th. And then that's gonna push out lab quiz 2 and then also lab quiz 3. Let me tell you, since I have you here, I can tell you. So 1 is going to be on the 14th, so that's going to be next Wednesday. Lab quiz 2 is going to be the 28th. And lab quiz 3 is going to be on March 21st, which is the Wednesday we get back from spring break. And then the rest will be the same, which will be the midterm and quiz 4 and the final, of course. Okay. So that is the quizzes. We're going to get signed off after this, so you are all set with that. So some people are going to have some issues with sign-offs, but don't worry, we'll get through it. So then I think the next big sign-off will be injections. So right now I'm planning on getting you guys done on Thursday next week after class, okay? All right, we'll hold that right there. So we have to finish up injections, and I think all we have left is IM injections. And I think that's where I was on Wednesday's group and everybody's group. Where IM was the last injection. And then we'll move into calculating IV drip rates, okay? And that isn't going to take too long. So, all right, let's get started with IM injections. So, you know what, we'll just talk first and then I'll go ahead and pass some syringes out so we can do some more drawing up of the syringes and medication and stuff, okay? Did we talk about IMs? I think we got started,
Yeah.
but I'm going to start from the beginning a little bit. So I'm going to start from the beginning of IMs. We talked about intradermal injections. Okay. Intradermal, which is very surface, just under the skin, which we do forearm. Also, this is just review, upper chest, could be upper back. Small, very small needle, small gauge, usually a very minute amount of fluid, 1/10 of a milliliter, so you know you're going to need the TB syringe, intradermal. Then subcutaneous, SC or SQ, appropriate abbreviations. Insulin and heparin are given by SQ, SC, by that route. Common sites, upper arm, anterior thigh, lower abdomen. Okay, so just making sure that you look at the site before you inject. Make sure there's no needle marks, bruises, lumps, bumps. People can get complications from injections. Okay? Okay, just keep for my IMs. All right, so then we will move into IMs intramuscular, okay? So again, complications, people can have pain with IM injections. Sometimes you hit some surface nerves. They could get some complications, some tissue necrosis, or tissue sloughing. And this is maybe from an inappropriate site selection or inappropriate technique. You will get better with it with time and practice, okay? So there are 4 muscles, and we'll talk about those in a minute, but no one's going to tell you where to go when you're given that injection. So as a nurse, you will pick the appropriate site, and that will be based on your patient's size, maybe the amount of fluid that you have to inject, okay, and that will help you choose your muscle site. Okay, so if your patient's getting maybe frequent morphine injections for pain, you always want to rotate sites. Look where you're going. Again, look for bruising, needle marks, feel for lumps, bumps, tenderness. Okay? So if you're going in one spot and it looks sore or feels sore, then you want to go somewhere else. Okay? So rotate the sites, and then they won't get complications. All right. Again, guidelines. So depending on what book you look at, the maximum amount of fluid that you should give in one spot would be 4 milliliters, which seems like a lot to me. But again, look at the size of your patient. Also, sometimes medication can be very viscous, very thick. So if you're given something that's real viscous, 4 milliliters in one spot would be a lot. You might have to think about maybe going 2 on one side, 2 on the other side, split it up, okay?
What would be an example of something that's viscous?
Viscous, got any, is it Ativan?
Dextrose?
Dextrose? I've only seen it in the big
Any
made, those great big, yeah.
Yeah, that stuff is thick.
And that's thick?
It's hard to push. I'm trying to think what else.
Ativan, I think, is pretty thick. So, yeah, you'll be able to tell by the look of it. Or if you're starting to draw it up and you're thinking, what the heck's going on? I'm having a hard time drawing it. Might be because it's so thick. There are some viscous medications. So keep that in mind too. So you're going to want no more than 4 milliliters, but most of the time it tends to be less than that. 1.5 milliliters, that would be okay. So that will help you figure out where you're going as well. If you have 2 milliliters, most likely not going to go in somebody's arm or the deltoid with that, because that's a lot. This is a smaller muscle, so there's some other muscles that can handle that better. And we'll talk about the muscle choice in just a bit, okay? So your syringe and needles, so the syringe, if you need 2 mLs, I'd go with that 3 ml syringe. The needle is going to be a little longer, so you need it to be 1 to 1.5 inches long, because we're going deeper now, right? We're going beyond that subcutaneous tissue into a muscle. .21 to 23 gauge. So it's a little bit bigger gauge than the ones that we were using, like on the insulin syringe, for example. Do you remember how big that one was? The insulin syringes were 29 gauge and ½ inch, little. Okay, so you're going deeper, so you need a bigger size needle. 21 to 23 gauge, 1 to 1.5 inches in length. And maybe if you have a very large client, you need to have a 2-inch needle. Okay, so you think about that too, according to your patient size. Okay, let me just grab a syringe here. Now the other thing that, is there any alcohol out here? Yep. The other thing that, thank you, that's a little, let's see, what's the word? Is it controversial, or the evidence isn't really clear on this? Aspiration. So by aspiration, I mean when you inject your needle into your patient, pulling back ever so gently, you don't have to pull back very hard, and what you're doing is checking to make sure you're not in a vessel, okay? Because if you pull back on the plunger, what will happen if you're in a vein? Blood, right? It's like getting blood drawn. When they pull back, that fills right up with blood. So you don't really need to pull back real vigorously. All you have to do is just gently pull back on the plunger, and blood, you'll see blood in your syringe here. So that means you're in a vessel, a blood vessel. So you wouldn't want to give it because maybe that would now be IV. So you might overdose somebody if you give it IV. So this is still out there. The book does talk about it. Depending on some of the websites and some of the schools even are teaching, do not aspirate. I don't think the evidence is real conclusive yet. So until it is conclusive, I'm going to teach aspirate. Oh, and were you, no, who was, nobody here. Patrick, who's in the second year, was telling me a story of when we were talking about aspiration last year, and he said he gave, it was a psychotic patient, and they were giving him a shot of something to calm him down. And he said he didn't aspirate. I think he went in the arm. I don't know for sure now what site he went to, but he gave it without aspirating. He said 2 seconds later the patient went and was out. And the next thing you know, he's now trying to resuscitate or revive the patient. And he thinks, though there was nothing conclusive, that maybe he gave that, whatever he was giving, in a vein, and he thinks that maybe that's what happened. He's not positive, but he thinks that might have been what happened, because when we
Probably the
got...
Haldol, because that's what we carry.
That's what you
Haldol.
carry for somebody who's a little out of control, maybe.
Mhm.
I don't remember, if it was some kind of psychotic episode, something was going on. So he was giving him the medication. Though I don't know, do you learn to aspirate out in the field? Which a lot of places don't even learn that anymore. So he said after that he will always aspirate. So, so
So what should it look like if you pull it up and it's
when you pull back, what are you going to find? What will happen?
You'll get a little
Blood. Normally, you're in a muscle. You shouldn't see blood in your
What should you
syringe.
see if you pull it up and you're in the muscle?
Nothing. Nothing. You might even get a little resistance. Now, if you pull back, nothing's going to happen.
Mm-hmm.
So, and then you would just push forward, which I'll show you the technique in a bit. But I like to just discuss that a little bit because I think even when you go to the hospital, different people have different schools of thoughts about it. So, in my years of nursing, when I aspirated, I got blood twice that I can think of off the top of my head. So that makes me aspirate all the time. Okay, so if you did aspirate and you got blood in the syringe, you're in a, what you would do is then immediately, I'd throw that away and start over. Take it out, start over, okay?
Would you get a whole new setup, or would you just replace the needle?
I do the whole thing. You could, I mean, theoretically, if you, I mean, that's the patient's own blood and everything, but if I injected blood into a muscle, it can be very irritating. And, yeah, I'd most like, you would want another needle, minimally, but if I'd get a whole new setup. Because there's blood in here.
So it's gonna make your drug count off, and you're gonna have to contact
Well,
your
now you gotta,
supervisor.
right, now you gotta throw this away. If it's morphine, you need a witness. Then you gotta go back and get another one, so now you have to explain. But, right,
Non-administered loss, right? You
pardon?
just do it as a non-administered loss?
I don't know how they do it, but somehow, you would definitely need a witness, and it depends on where you work. So if I'm in the hospital, you'd have to be my witness that says, I threw this away, this is what happened, and then you could go back and you'd probably have to do something in the Pyxis.
Well, even in the field, we have to get a witness, a nurse witness if we give any narcotics, if we have any waste.
Anyway,
We don't
yes.
give it all.
Yeah, because, yeah. So, that's aspiration, so, and the reason that they say it's not necessary anymore is, one, the chances of you hitting a blood vessel are very, very small, depending on what muscle you're using, okay? And two, as you pull back to aspirate, it could cause some damage to the muscle. I mean, you're not vigorously pulling back. When you have the needle in your page, you're just gonna, just very gently, because the minute you pull back, you will see blood right away. You don't have to wait for anything. It comes right in, okay? Think about getting blood drawn, you know, how when they stick the needle in and pull back, you get that flash of blood right away, once you're in, okay?
And you would just pick a different location if you have to pull back and start over.
Probably, yeah, you have to start over. And then the other thing is that there is a site called the dorsogluteal, this one in the back here, dorsogluteal, which isn't recommended. It's the least, what's the word? The least preferred, thank you, that's the word. The least preferred site. So our book says if you go in the dorsogluteal, you will always aspirate because there's the chance that you're going to hit a vessel. But there's also a chance you're going to hit sciatic nerve, and that's why some places are saying you can't use that site anymore and taking it right out of their protocols, okay? So if you go into any of the other preferred sites, the chances of you hitting a vessel are very small, okay? So let's talk about those and then we'll go back into technique, okay? So the preferred site, you'll get one of these if you didn't already, okay? Ventrogluteal, the ventrogluteal, okay? That is the muscle on the side of the hip. So it's on the side of the hip, okay? So you do need to know these muscles, okay? And how to find where you're going to inject, okay? So on this handout, do you see where the hand is, how it's kind of got the superimposed the bone? So there's the greater trochanter is sort of I guess it's superimposed, is that the word? Right below the V, I guess, of that. Can you see it? Can you find it? See how that, yeah. Do you see it, Jacqueline? Rebecca? You see it? Kate? You guys? You can see it. Can you see it, Sarah? Yes, okay. So that's what you're feeling for. So what you're going to do to find this site, feel around, and what you're really feeling for is the bone, the greater trochanter, okay? And it does tend to be, where you're going to go tends to be along the seam. This might be back a little far, but it just tends to be along the side of the hip. So feel around, feel for the greater trochanter, okay? When you feel the greater trochanter, the palm of your hand is going to go over that, okay? So think about the greater trochanter, where the leg is attaching to the torso, or the kind of like the bend here, that's the hip joint. Feel the greater trochanter, okay? When you find it, your palm goes over the greater trochanter with the fingers pointing towards the head, okay? Did you find it? Okay? So I'm feeling around, feeling for that greater trochanter, palm over the greater trochanter, fingers pointing towards the head of the patient's body, okay? So I'm feeling. So with the fingers pointing towards the head, right in between these two fingers is where you're going to inject, okay? So sometimes I'll just draw a line, my imaginary line. No, like this, not like this, like this.
Look, if it's easier to do that though, then.
Is it easier? But you got to be in the right spot. Make sure you're right along. Okay. So, palm over the greater trochanter, fingers pointing upward, and then in between, this is where you're going to inject. So you might feel like it might be kind of high up, but it is high. It is high, okay? I always like to take the bend of the knee and I'm going up from there. Or bend at the hip,
So thumb facing forward.
The fingers point towards the head.
What's your,
Just point your fingers up towards the head.
I
Your
got
thumb,
it.
you mean?
yeah.
Yeah.
Well, I guess
If
it
you
could be
go-
either hand. See, now this
If
is
you go
this
the other way,
person's.
then you're out of that area.
No, no, you're gonna feel for your greater trochanter.
Right.
So put your greater trochanter or your hand over that, and your fingers will be facing up.
Right.
So you mean if you have the,
Then your V is in a different location.
well, you gotta work it. Check it out on this guy. I'll pass it around. Feel him. You actually can't feel her greater trochanter. But do you mean, I don't quite.
If you go like, if you're doing this or whatever, and you have your fingers here, and this is facing the front of the patient, or you do this way, your fingers, see the difference in the V's? Where's your V?
Where's the difference?
Your
I don't know,
location.
maybe I'm just pushing my hands over there all the time.
See if you use two different hands, your V's in different locations.
You gotta check it out on a person and see what you come up with. What's this one doing?
Thumb forward.
Thumb forward on that one. So thumb forward. I don't know about that. This way. We'll have to try it. Because I automatically shift my palm. So let's check that
Because
out.
you know where, you know.
Because I know where I'm going.
Right.
If you're not sure. Well, let's look at your book. Let's see what else your book says, if it gives you any other guidelines. So we're going to stop in a minute, and then we can do that. But that's a good muscle because there's not a lot of major blood vessels. There's not a lot of major nerves there. So again, according to the book, if you didn't aspirate here, the chances of you hitting a vessel are very, very minute. Okay? Would I aspirate? Personally, I would. So that's why I teach you to aspirate, because if you actually take a poll of all of your professors here, I think almost everybody has hit in a blood vessel in their years of nursing. So that's why we say, oh, yes, do it. But all right, so ventrogluteal. The deltoid is up here in the upper arm, the deltoid. Smaller muscle, so if I have to give maybe 1.5 milliliters of fluid, I don't know if I'd go here. 1 milliliter. Flu shots or IM, we got the flu shots here, remember those? Yep. So it is, what?
We remember yours.
Yeah, remember mine? Did you see them?
Yeah.
I showed you guys.
Yeah,
I
because we
didn't
said
show
you-
everybody. Wish I didn't take, why didn't I take a picture of that? Yeah, it was like it was like the color of the sweater, it was completely bruised and, yeah, technique again. So you want to, it tends to look like that triangle, upside down triangle. So feel for that bony acromial process up here on the edge of the shoulder. And you want to put 2 fingers underneath that. And then you're going to go right underneath that. Okay, that's a good muscle to go to. If you have somebody with some, I guess, meat, muscle.
fingers under the.
Feel for the acromial process, which is the bone there. Shows you right on that picture too. And go 2 under, and then you're going to go under that. And this is why I always palpate, because I feel for a bouncy muscle where I'm going to go with an IM injection, because that's where you want to go, into like the belly of the muscle. Okay? So deltoid, okay? Vastus lateralis is on the top of the thigh, okay? Well, slightly lateral. So to find this site, you want to, you're going to go to the middle third of the leg. So what you would do is take your hand and put one hand just above the knee, okay? And then one hand at the very top of the thigh, okay? And then you're going to go in that middle third area, okay? So it's not right on, it's slightly lateral. And it's not directly on the side, okay? So you want to go slightly lateral, okay? See that? So middle third, slightly lateral. When you look at this picture on here, I think this looks very, like it's on the side, but it's not directly on the side. It's slightly, and it's not directly on the top, it's like so, okay? Personally, in my experience, I feel like this one causes the most pain on a patient. I don't know why.
1/3 up.
No, the middle third. So this
the
is
middle
how you
third,
got the
gotcha.
middle third. Your hand over the knee, the other hand at the top, and then that middle third section, okay?
That's what they typically do for children, like infants, when they're giving them some of their.
For children,
Yeah.
yeah, they use
Some of
that.
their first vaccines.
They go there a lot in kids, yeah. Now, the one that's the least preferred is the dorsogluteal, and that's the one and the back side here. So, and it's because of the sciatic nerve, okay, because the chance of hitting the sciatic nerve. So, maybe you work someplace, some people were telling me different places where they always give the, is it the Depot shots in the buttock area? And some people were telling me different places where they work that they always put them there. But maybe you're gonna work somewhere where that's a preferred site. So you have to know how to give it so you're gonna be safe, okay? So the way to find this spot, or the injection area, take your half of the buttock that you're gonna go to and divide it into quadrants. So I just divide an imaginary quadrant area. And then you're gonna go to the upper outer quadrant, upper outer, okay? So when you do this, the upper outer is up here, see that? So I'm well away from the sciatic nerve, which is the white right there, okay? So you can see where you want to avoid that. Upper outer, okay? So when you're given these injections, you know, I'll just do it and then I'm gonna, I'll pass out some stuff so you can drop some solution and give it. But I wanna just show you the technique. And don't forget, you will always wear gloves when you administer injections, but it's not always necessary to wear gloves when you're drawing up the medication or the solution. It depends on what the medication is. Okay, so if it's a medication, what do you do with that syringe? Here it is, okay. So if it's a medication that maybe is a chemo drug, you will always wear gloves. So it depends on the medication, okay? So with this medication, or when you administer it, you have your gloves on, okay? So when you go to cleanse, well, first of all, find your muscle. Choose where you're going. I can do it here because, okay. Let's find, I think you can see better if I go here. So let's find a muscle. Oh, that's good. So if you're going to palpate, which is a good idea to do because maybe it's tender or sore or you feel some lumps, bumps, so always palpate before you cleanse. Because once you cleanse, consider it sterile, okay? So I'm going to find my spot and I'm going to do concentric circles, okay? Concentric circles. Okay. So here's my medication. You want to pull the muscle taut. You don't want to bunch it up. Remember how we bunched it up for the sub-Q? You want to just pull taut. So I'm pulling taut, and you're going to go straight in at a 90-degree angle. Okay. So I go straight in, I pull back to aspirate, and then I push the medication in. So I'm pulling taut, straight in, like a dart, okay? Now I'm pulling back ever so gently, no blood, and then I can just push it in and pull straight out, okay? And then of course you want to either retract your needle or put it immediately in the sharps container. Now if you, if it starts to bleed or it shouldn't leak at all, you can massage this one. Where the other ones we didn't massage, we just dabbed. It's okay to massage this one, okay? Because maybe we're given morphine and it's okay because we want that to get absorbed. So
Do you cleanse it with alcohol afterwards, like you just did?
If you want, if it's leaking, I will. If it's not leaking, or if it, I might not.
Okay.
You don't have to. Okay? I think that's all about IMs. So you know what I'm gonna do? We're gonna practice a little bit. So I'm gonna turn this off because